In today's class, let's learn about pathophysiology of hyperkalemia. So, the causes of hyperkalemia. Firstly, hyperkalemia is serum potassium concentration that is greater than 5.5 milliequivalents per liter. And there are multiple causes which can cause hyperkalemia. The first primary cause is increased potassium intake. So, when the intake of potassium increases in comparison to its excretion, hyperkalemia is seen in patients. The second cause is decreased potassium excretion. The third cause is tubular unresponsiveness to aldosterone. In this case, aldosterone levels are normally present, but its binding to the receptors is not seen and its action is reduced. The fourth cause is redistribution of potassium into the extracellular space. Let's learn in detail about the first primary cause, which is hyperkalemia associated with increased potassium intake. Patients with stage 4 or 5 CKD and dialysis patients who are non-compliant with dietary potassium restrictions often present with life-threatening hyperkalemia. So in stage 4 and 5 CKD and dialysis patients, the renal function is reduced to a great extent. So potassium excretion is greatly reduced. And if their intake or dietary potassium further increases, it would cause a larger imbalance and they may present with life-threatening hyperkalemia. Many over the counter herbal and alternative medicine products may contain significant concentrations of potassium. Noni juice has been implicated as a cause of hyperkalemia in patients with renal dysfunction. So, noni juice is obtained from a tropical fruit, and this has been traditionally used medicinally in the Pacific Islands. And this juice is known to have high concentrations of potassium, and its intake might cause life threatening situations, especially in patients with renal disorders. The second primary cause, which is hyperkalemia associated with decreased renal potassium excretion. When the kidney is unable to excrete potassium appropriately, as in acute renal failure and stage 4 to 5 CKD, potassium is retained and often results in hyperkalemia. So, as I mentioned earlier, patients with ARF and stage 4 to 5 CKD have highly reduced renal function, which causes decreased potassium excretion, and this often results in hyperkalemia. Severe hyperkalemia is more common in acute renal failure than in CKD, since in ARF, tissue damage is observed and that may cause leakage of potassium into the blood serum. Renal excretion of potassium is also inhibited by various endocrinologic disorders, including adrenal insufficiency, Addison's disease, and selective hypoaldosteronism. So, all these disorders have a common characteristic, which is reduced aldosterone action. So, aldosterone has a very important action of excreting potassium. And in these endocrinological disorders, aldosterone action is reduced and thus potassium excretion is greatly reduced. So, it might cause hyperkalemia. Some drugs that may cause hyperkalemia: angiotensin converting enzyme inhibitors, also known as ACE inhibitors, angiotensin 2 receptor blockers, ARBs. Both these classes of drugs are also known to reduce the aldosterone levels, and thus potassium excretion is reduced and it causes hyperkalemia. Potassium-sparing diuretics, they are aldosterone antagonists. Prostaglandin inhibitors, such as non-steroidal anti-inflammatory drugs. NSAIDs are known to decrease GFR, which further causes hyperkalemia. Other commonly used drugs that can cause hyperkalemia are digoxin, cyclosporin, tacrolimus, trimethoprim sulfamethoxazole, heparin, and pentamidine. Our next primary cause is tubular unresponsiveness to aldosterone. In this condition, aldosterone levels are normally present in the body, but its binding to the aldosterone receptors or site is greatly inhibited or reduced. So, this could be observed in certain medical conditions such as sickle cell anemia, systemic lupus erythematosus, and amyloidosis. These conditions can produce a defect in tubular potassium secretion, possibly as the result of an alteration in the aldosterone binding site. Next primary cause is redistribution of potassium into the extracellular space. So this cause is particularly seen in the presence of certain disorders like metabolic acidosis, diabetes mellitus, chronic renal failure, and lactic acidosis. These disorders may cause an efflux of potassium from the cell into the extracellular fluid, which results in increased potassium levels in the serum. Beta blockers can also result in a transcellular potassium shift. Truly elevated potassium concentrations are associated with low carbon dioxide, acidosis, or elevated blood urea nitrogen and creatinine concentrations, which indicates renal insufficiency. These are certain laboratory parameters which could be associated with potassium concentrations. That's it for today's session. Thanks for watching and please share this video. Thank you.